So we'll just give it an extra minute or so and then we'll get started. Morning, Joan. Welcome. Actually, we're on afternoon now, I think, aren't we? It's 12:30, so.
We are. We've crossed over the line.
We've moved over.
Downhill to the weekend now.
Afternoon, Erin. Lovely to see you. Right, we'll just give it a moment, because we did have nearly 60 people register, so we'll just give people a moment to join. Morning, Liz. Lovely to see you. So if you've just joined, please do put your name and role in the chat. No worries. Yes, this is an ideal lunchtime slot, so feel free, Liz.
I think that's part of the challenge as well, isn't it? People are finishing up clinics and stuff.
Morning. We're just giving people a moment or so to join. So if you've just joined, please do put your name and role in the chat, and we'll get started in 12:35 or so. Right, I think we will get started. We are recording the event, so the recording and slides will be sent out after. But a huge thank you for joining on where I am is a slightly snowy, cold lunchtime. So fantastic to see you all, and welcome to this webinar, which is all around CVD action and how it can enable a step change in CVD prevention. And if we just go on to the next slide, we'll just say a bit about who we are on the call. So today we're going to tell you all about CVDACTION. CVDACTION is a smart data dashboard and wider program that was originally developed at UCL Partners, which is a health innovation network based in North Central and North East London. because of the success and the interest in the programme, a spin-out company has been set up to spread and scale CVD Action nationally. It's led by Dr. Matt Kearney, OBE, who you will meet shortly, and many of you will know him, a former National Clinical Director for CVD Prevention, and myself, Laura Boyd. Now, CVD Action is a programme that has a kind of an implementation part to it, and so we have partnered with IQVIA to support that spread and adoption. And I'm just going to hand to my colleague Dan to say just a few words about IQVIA.
Hi, good afternoon, everyone. So myself and Zainab on the call are from IQVIA, which are a global data science company. We work a lot with the NHS, both in primary care, secondary care, and with clinical research. So just in our primary care division, we've been established for about 20 years. We employ around 160 fully employed pharmacists. We've worked with all 42 ICBs last year, around 3,600 GP practices, and around 200 of the 1,200 PCNs nationally we would consider as being partner PCNs, so those that we do multiple work streams with. So delighted to be here and delighted to be supporting the CVD Action programme.
Excellent, thanks. So today we'll be covering the background to CVD Action. Why was it developed? We're going to give a thorough overview of what it is, what you can see in CVD Action, and Matt will talk you through the dashboards that make up the data platform. We'll then talk about the implementation support. That is a core part of the programme. We'll talk about some of the funding options to be able to fund and bring CVD Action into existence in your locality, and then we'll talk about next steps. We are recording this session, but if you would like to have questions, please do use the chat to put them in. We'll also have an opportunity at the end to ask questions. So I'll hand to Matt now to take us through that first section. Thank you.
Thanks, Laura. Yeah, afternoon, everybody, and great you're able to join at busy lunch times. So we developed CVD Action with a specific purpose, and it was to build a solution for the problem, the challenge that we have in CVD prevention. We know how big cardiovascular disease is. We'll all know these numbers, I'm sure, but it's a huge driver of healthcare expenditure and social care expenditure, big driver of health inequalities, accounting for a fifth of the life expectancy gap between rich and poor, and of course devastating for individuals and their families. The next slide, please. The CVD prevention mission introduced by the government when they first came into power, and which is underpinning and informing the 10-year plan, is that we will, as a country in England, reduce premature deaths from heart disease and stroke by a quarter in 10 years. So that's a big ask. And next slide, please. And it's a big ask based on the understanding that cardiovascular disease is highly preventable. Of course, through support for behaviour change, behavioural risk factors, helping address wider determinants of people's exposure to risk, etc. And that's all critical for the long term. But there's also the prevention that we do as bread and butter in general practice, particularly. That's managing these high impact risk factors that cause cardiovascular disease. And what we know about them is if you treat them, there's a straight line of evidence between treating them and preventing cardiovascular events. Next slide, please. The challenge we have is that despite what we know, and that we've known for a long time, and despite nice guidance, many people are not on appropriate treatment. So 1 in 3 people with hypertension are not treated to target. And you can imagine from a patient perspective, if you're told, you have blood pressure and we're going to put you on treatment, but you've got a 1 in 3 chance of not being treated to target, is surprising, and would be surprising if we articulated it that way to patients. And within that, the national average is 1 in 3. But actually, if you look at every practice in the country, in some practices, over 90% of patients are treated to target. In some practices, it's around 40%. So there's huge variation there contributing to the health inequalities And we see the same sort of undertreatment in people with high cholesterol, cardiovascular disease, people with CKD and diabetes. And we know from the modelling that we'll show a bit later and that we've featured in our webinar a couple of weeks ago that this causes thousands of avoidable heart attacks and strokes and other cardiovascular events every year in England. And all of this has happened despite having nice guidance, despite QOF and despite care quality commissions, all those levers, and yet not a lot has changed in recent decades. And that was spotlighted, really pulling no punches in the 10-year health plan. The NHS has avoided taking its responsibility seriously on secondary prevention. That's stark and it's true, and I've no doubt that that will inform much of what goes into the MSF, but we'll see what when that's published. So that's the case, that's the reality in the management of these conditions. But in thinking of solutions, we have to unpack the problem. And it's critical to acknowledge that optimal treatment of these conditions is not easy to do in real-world primary care. Nobody's got any capacity. Our consultations are all far too short. Our patients have far too much that they need help with sorting. And these conditions are asymptomatic generally, so patients don't have an alert to tell them that their blood pressure or their cholesterol is suboptimally managed. And of course, our pathways are very reactive. We have QOF. Sorry, go back a slide, please. We have QOF, and that drives a lot of our behaviours in long-term condition management. We tend to recall people by the anniversary of their last QOF review in order to meet those QOF targets. But it means that if in those brief review appointments we don't pick up that the blood pressure is not optimally treated, or the cholesterol, or the CKD or diabetes, and there's an awful lot there to do with one patient in a short time. If we don't pick it up then, we won't pick it up until the next year unless they turn up with a complication, an exacerbation, a serious life-changing event. And that's the reality of it. We do our best, but this is what our best delivers. But the other critical element is that we don't look for the patients who are undertreated. So that we know this now from CVD Prevent data, that many are undertreated. We don't have any systematic way of looking for them. So we don't know the size of that problem, and it doesn't trigger a change in our ways of seeing patients. But that's the real world. And our thinking in building CVD Action and the related resources was that this is what we've got to address. It's no good just putting guidance and data and incentives in place if we don't help primary care to do things differently. So next slide, please. So we have loads of search tools, and this is just a sample. We have lots of projects and incentives. Many tools out there are really helpful and do really useful things, and some people use them to great effect. But many are sort of very narrow in their perspective, just one condition or one indicator, for example. And many are really very hyper complex. Great if you're trying to take a population health view over a big population, but of limited value if you're trying to change the way you do your day-to-day practice. But what they all have in common, these tools, wonderful or not, is that they don't address the real world challenge, that whatever the data tells us, we don't have the capacity or ways of working to act on that data. So this was critical to our understanding in building CVD Action. Next slide, please. So, and the next slide. So I'm going to take you through now what CVD Action is about, and I'll show you a demonstration of some screenshots to see how you can see how it works. And we will have plenty of time for questions at the end. But so CVD Action is a starting point is as a data platform. We built it for Emerson System 1, but also SQL, for people who knows what that means, but it means it'll sit in any integrated care record system across a wider population. It's now embedded in Eclipse, who we've also recently partnershiped with, so it makes it instantly accessible to over half the practices in the country. And in fact, they can provide access to every practice in the country. But we do also have alternative ways of technology of delivery. And it gives you practice and PCN views, but it also gives you system views, which is very helpful from a population health perspective. Next slide, please. So Many of the tools that we have a narrow spectrum, and our starting point, a few starting points here. One is make it dead easy, has to be very easy to use, with minimal user input required. Secondly, that it's comprehensive, so it covers all of the key cardiorenal metabolic conditions. So the 6: blood pressure, cholesterol, AF, CKD, diabetes, and pre-diabetes that we built into CVD Prevent when we developed it, and we're now adding obesity and heart failure. And the key function at its heart with CVD Action is that it finds every patient who's on suboptimal management, who's not on NICE guideline directed therapy, including monitoring, testing, coding, or drugs. So it'll find all of those patients across the 6 conditions, and it brings in comorbidities, so you can see all the CVRM conditions that a patient is not managed to adequately. And it's all about simplicity and turning big numbers into little numbers, so I, as a local clinician, can fit it into workflow, match it to capacity when we have no capacity. And I'll illustrate in a moment the holistic approach and also the specific health inequalities function. Next slide, please. So these are screenshots, which is the easiest way of demonstrating it. Across the top, you click on the condition that you want to look at. The 6 conditions there, and we'll be expanding this as we add obesity and heart failure and the new conditions in the future. And each condition has the same sort of approach. So with hypertension, you've got the index problem, if you like, blood pressure not treated to target. But as we know from NICE, managing hypertension is not just about blood pressure, it's about the wider CKD risk, CVD risk, it's about CKD management, it's about detecting atrial fibrillation when you check the pulse rhythm, as we're all supposed to do before we measure blood pressure, but most of us don't get round to doing. Each of the bars it is one group of patients, one cohort. So if you click on one or you click on multiple ones, you then get lists of patients. So move forward one slide, please, and the next one. So I've clicked on blood pressure above 180 or blood pressure between 160 and 80. So because I know, I mean, that's a high priority for me, the patients whose blood pressure is very high. So as a clinician, I can immediately get that list of 46 patients, so that feeds into workflow for the staff. You can't read the detail here, but for someone using this, against each patient's name, it would tell them all of the CVD action indicators that their patient's not meeting, so they can take a holistic approach in managing. If you just go back to onto the next slide, please. And looking at the hypertension dashboard again, what this does is it finds every patient who's suboptimally managed, but then allows me as a local clinician to see where the priorities lie. And that will vary from place to place. But that's what we are unable to do with sort of searches in general. We might know that something's important, so look for our patients with hypertension who are suboptimally managed, but we worry about all the other patients out there who we don't know about, who may be a priority. CVD Action will show you all the priorities so you can then select. So if you look at the second panel, wider cardiovascular risk management. So these are all my patients whose cholesterol is suboptimally managed, and it's a big number. But actually within that, we've stratified. So there's 48 patients who've got both hypertension and CVD or on no lipid-lowering therapy. So 2 big risk factors, not on appropriate treatment, very high risk. If I bring them all in and get them all on statins, I know that's not real world, but if I did, I would prevent 5 cardiovascular events just in my practice, just in this cohort in five years. And you can see the further stratification there. So CVD on the statin, but not the maximal dose or intensity. CVD on the maximal dose intensity of statin, but not treated to target, and the primary prevention ones. And you can see the CKD and atrial fibrillation indicators also. And an example there is the CKD. There are 74 patients with hypertension and CKD who've not had an EGFR or ACR done in the last year. Well, those people don't need to see a clinician. That's a non-clinical clinician workflow who can arrange for those tests. So it allows that to fit into workflow. If you click on again, you'll see at the bottom there's a show demographics button. If you could just click on once more. Zainab, thank you. You click on the show demographics. This then automatically filters any one indicator or groups of indicators by age, gender, ethnicity, deprivation, severe mental illness or learning disability. So even in my practice, I can find my 11 patients who've got severe mental illness, whose blood pressure is poorly managed. Those patients will die on average 10 to 20 years early, and they won't die of severe mental illness on the whole. They'll die of heart attack and stroke and similar conditions. So even at practice level, I can take targeted action on health inequalities. But because you could get this at neighbourhood or federation or ICB level, a view at those levels, you'll be able to find all your patients across an ICB in a deprivation quintile or an ethnic group whose blood pressure or CKD or diabetes is poorly managed. So you can then take strategic action across the ICB to support those patients to access better care. Next slide, please. And the next one. And the final bit to show you on here is the case finder. If we just click on one more, on most of the conditions as a case finder, it'll find all my patients who are not on the hypertension register, but whose blood pressure more than 3 months ago was above 140/90. And you see the same for CKD and diabetes, etc. Next slide, please. For cholesterol, and I'll go through these more briefly, but you see the same breakup to get from big numbers to little numbers. We've got 261 patients who are high priority. They've got CVD and their lipids are suboptimally managed. 78 patients, CVD or no lipid lowering therapy. 116 are not on the maximal dose intensity of statin, and 69 would be eligible for drugs like inclisiran. And then there's a primary prevention group of cohorts and familial hypercholesterolemia. So I emphasize that finding these patients doesn't mean they need to go onto those treatments. What it tells me as a clinician is they're not on the guideline-directed treatment. So at a start, they need a desktop review because it may be appropriate, the dose or the treatment they're on, but it allows me as a clinician to make that safe appraisal and then recognise there will be a large number who actually need further appointments and further help. And the next slide, please. And then chronic kidney disease and diabetes are the next two. It looks a bit more complicated. In chronic kidney disease, we're trying to do two things. One is prevent end-stage renal disease leading to expensive dialysis and transplant. But about half of our patients with CKD will end up dying from cardiovascular disease, heart attack and stroke, etc. And we want to do, so to prevent those outcomes, you do four things in CKD. You optimize blood pressure, you optimize cholesterol, you get them on renin-angiotensin antagonists, and you get them on SGLT2 inhibitors if they're indicated. So the dashboards allow you to go from big numbers to little numbers. You can see all those small numbers, 6, 13, 9. These are in nice determined cohorts where they're eligible for drugs depending on what their ACR level is, depending on whether they've got hypertension or diabetes, etc. So you can pick off one or multiple of those cohorts in one go. And you see the 61 patients there who would be eligible to be considered for SGLT2 inhibitors, which we know is highly effective in CKD, but probably most of our patients who are eligible don't get onto the drug. And then the lower bit is about blood pressure management and lipid management in our patients with CKD. Again, you can click on show demographics. You can stratify this by age, gender, ethnicity, deprivation, severe mental illness at a practice level or a PCN level or across an ICB. So again, you can take targeted action on health inequalities, which we know CVD is a major driver of. Next slide, please. And then diabetes. I won't do the detail on this, but you'll see the same sort of comprehensive multi-morbidity approach. And we're substantially updating this in readiness for the new NICE guidance when it's published in the next month or two. So that will look different, but it's the same process. Big numbers to little numbers. How can I prioritize safely? How can I get numbers that fit to workflow and know that the interventions I'm acting on will have a major impact on outcomes, even at practice level? Next slide, please. And then there's one for pre-diabetes or non-diabetic hyperglycemia, which of course is not just about exercise. It's about that wider cardiovascular risk management, blood pressure, lipid management in my patients with pre-diabetes. And the next slide. And there's one for atrial fibrillation. Again, we focus on anticoagulation, which is critical but we very often forget that actually more of our patients with AF will die from some other manifestation of cardiovascular disease driven by their hypertension or their lipids or their smoking or whatever. Next slide, please. So I'm going to hand over to Laura now. That's the data platform, and I'll hand to Laura.
Thanks, Matt. So Matt's taking you through the data platform, but of course we all know that data and tools and dashboards themselves don't drive the change. And so the wider CVD Action programme really looks to tackle this head on. So data is there. As Matt's shown, easy to action, a way to routinely identify all patients who might need to be started or continued on treatment. But the kind of the value adding piece to the programme is how do we support teams to be able to embrace and to utilise that data so that something happens once those patients have been identified. So the two wider elements of the CVD Action programme are, secondly, that structured implementation support. So thinking about how do we adapt work pathways, think about how you use the wider workforce to be able to optimise and support those patients. And include the breadth of the workforce within primary care teams. And the third piece is that relentless focus on outcomes to ensure that despite all the activity, the desired impact is being had. So the wider programme really thinks about how do we share data quickly to make sure that that impact in terms of seeing and optimising patients is happening. So those are the three kind of pillars that we've set up as part of the CVD Action programme. And if we go on to the next slide, I'm just going to talk through that in a little bit more detail. So Dana, if you can click on one, that'd be fantastic. So that first bit is that data. So data that we can trust. It reads across existed coded data within the primary care health record. And there's a real acknowledgement that if we pull out the data, that's just that first step. And so we've developed the programme to be able to support you both stratify and place that data into manageable chunks. So Matt has shown how it's set out by those high-risk conditions, but how you can also stratify to target inequalities. But we know that there's more that's needed to move from just seeing people annually on their birthday, as has been the standard, to think about how we prioritise people according to risk. So seeing people in a different order according to their risk profile. So if we click on to make that happen, there's a structured support programme really to help that adaptation happen, which encompasses everything from thinking about your workforce that you've got available to you, not being prescriptive in what you must have, but thinking around who is available and who can support interactions with those patients. And that ranges from everyone, from the receptionist to the individual that might be booking people into appointments, to your clinical pharmacists, to your practice nurses, and so on and so on. So that support is there. Now, one of the things that patients told us when we did the kind of patient and public engagement around this programme is that they really wanted to be supported in the fullest sense of their wider health and not just spoken to about a specific condition. So the principle of kind of a holistic approach to care is really part of this programme. And then the third aspect is that kind of focus and that relentless focus on the outcomes. So again, this programme doesn't specify what you have to do. The idea behind it is we would work with each team to understand, well, what's important to you? What are the changes that you want to make? What are the objectives that you'd like to set? And then support you through, a rapid kind of QI process to think about how we make that happen in practice. And Dan will talk, shortly through some of the support that's available to make that happen. So if we go on to the next slide, so you'll all be asking, well, how do we know this actually works in practice? So we've conducted 2 evaluations, and we'll just talk, shortly about those. So our first, we tested CVD Action in a population of 600,000 across 10 primary care networks in London. So if we just go on to the next slide, if that's okay, thank you. And we found the programme was very well received. So we saw PCNs adopt the programme and adapt it in different ways that suited both their workforce, but also what was appropriate for their populations. So some used specialist pharmacists, others worked with the breadth of their workforce and involved colleagues who had a special interest in motivational interviewing. We saw a cultural shift away from calling by date of birth to calling by risk. And we also saw kind of innovation in how workforce was involved in the pathway. Broadly, the feedback was very, very positive in how CVD Action was received, and we'll provide some quotes to that shortly. But in terms of the hard numbers, if you click on once, we did see, a very, very short time, an impressive increase in the numbers of patients treated target. So if you click on one, those numbers should flash up. What we will do shortly is we'll put the link to the report in the chat so that you can see that in more detail. If we go on to the next slide, I'm just going to spend just a moment or so just talking about one of the GP federations in southwest London who adopted CVD Action. The majority of the population within the PCNs who were testing it or piloting CVD Action are based in a very poor area called Roehampton. You might remember during the news, during COVID, there was a lot on the TV around this estate, the Alton estate, because of the significant health inequalities and the real anxiety about how people would cope during lockdown and so on. But the area is an area of deprivation, very poor transport links, a lack of good food shopping options. English predominantly is a second language. Farwer, the clinical lead who led kind of the implementation of CVD Action, really had a really in-depth understanding of the health inequalities in the populations that she was supporting. So she recognised a couple of things. She really needed to think about how to talk to her population about CVD Action and why they might want to engage when contacted about their blood pressure or their cholesterol. And she used a very kind of innovative way to approaching the communication. So she really talked about this as something that they'd secured for their populations and communicated that out to people as such. So, we've secured this programme. Please do get in touch. This is for you. And really kind of thought about how she communicated it to them. She also recognised that they had a breadth of different workforce across their practices. So Farwer spent time with them really thinking through, well, what support do they need to be able to make sure that they are seeing patients and communicating in a way that works for the local population. They spent a lot of time thinking about the approach taken to motivational interviewing and involved healthcare assistants as well as clinical pharmacists in the pathway. Farwer felt that she had a really strong understanding of the health inequalities across the region. But even she said, I did not expect to see, women in their 40s with uncontrolled high blood pressure come through. So there was a real focus on thinking about how do we use this programme to tackle some of those health inequalities. So I won't say anything more to that case study now, but I'm really happy to talk to it at the end if that's useful. And then our second, some of the quotes from some of those early adopters are here, and I'll leave you to read them yourselves. But the next slide just talks to our health economic impact model, which again, we won't say too much to because we held a webinar on it a couple of weeks ago. But Matt, do you want to speak to that?
Yeah, thanks, Laura. And with the large demonstrator programme, in the evaluation, we were asking the question, well, if we support primary care to do things differently, will it deliver step change improvement in the management of these conditions? And the answer was yes. But then the next question we wanted to get an answer to was, well, if we were to do this at scale, what would be the impact? We know these treatments are all effective. There's a straight line of evidence, etc., from treatment to outcome. But what would be the impact? So we modelled this, and if you use the QR code, which you may have caught, but if not, you'll get the slides and you'll be able to follow it. You can see the model itself that we had built and the national report, and there's a report for every ICB, a sort of 5-page headline report. Oh, the next slide. I was trying to move the slides myself, but and the basic model was we looked at 4 treatments: blood pressure, cholesterol lowering, renin-angiotensin, SGL2s, that are used in those 4 conditions. They were all NICE recommended, high impact, mostly inexpensive, but all underused. And next slide, please. So, as Laura said, we won't do too much detail on this as we've had the webinar previously, but this looks at the lowest scenario, step change, which we described as the minimum realistic improvement we should be going for. And as an example, that would mean moving from 67% of patients with hypertension treated to target to 80%. So, not a big deal from a patient perspective and should be within our grasp to do it. But just look at the impact on outcomes. If you optimize the uptake of those 4 treatments, you prevent almost 62,000 heart attacks, strokes, end-stage kidney disease and heart failure admissions in 3 years. 470,000 bed days is 2 hospitals emptied for over a year, and £2.5 billion generated, half of which is health and social care, half is the wider economy for keeping people working, and that doesn't include the fiscal benefits of lower benefits and increased taxation. And so within 3 years, I mean, these numbers are astonishing, but for every £1 invested, you get £4 back. And critically, when we're thinking about how do we finance the prevention shift, ICBs would get return on investment within 1 year, even taking account of the costs, not only of the drugs, but the costs that we've described for supporting transformation in primary care. So really striking numbers. Do go to the website and look for your own ICBs, and we've developed reports for the cluster ICBs also. The next slide, please. So I'm going to hand to Dan now.
Thanks, Matt. So, like we mentioned at the start of the call, Into Action have partnered with IQVIA, who have a large primary care presence, to support predominantly primary care to help to achieve a step change in CVD. These are some of our credentials. So as you can see, we've been operating for around 20 years. We worked with around 3,600 GP practices in the last 5 years, and around 200 of the 1,200 PCNs in England we would classify as being partner, i.e. those that have worked with us on multiple programs of work already. Next slide, please. So as mentioned earlier in the call, the platform, as we've seen, is a really great platform, and a lot of the NHS is awash with data, but is it really about how we can support primary care to achieve that step change? So our support can range from operational, logistical, implementation, as well as workforce development, and then sustaining the project beyond the initial term. So this can range from embedding the platform, getting all the GP practices within a locality set up with the platform, training them in how to use the platform, working with their leadership teams to look at how they can start to implement it and agreeing KPIs with them, tangible, realistic KPIs that are sustainable. How do we get that tangible commitment? How can that organisation use its workforce? How could it use its workforce differently? What steps would be needed to try and improve the confidence and the competence of their staff? Also supporting with project management throughout the programme. A key part of it is looking at the kind of the junior and emerging clinicians within the NHS and how we can support them to take on more of a holistic CVD focus. So this is looking at things like training needs analysis, competency frameworks, using action plans and key performance indicators to track and monitor progress, and then supporting that next generation of leaders within the NHS to take on more responsibility and accountability locally, and really champion this step change across the locality. Once we've done all of those things, then it's about gaining progress metrics. So one of the hard things with NHS programs sometimes is getting meaningful data back out to show how the NHS is doing, but also then how can we sustain it to become business as usual, and it becomes part of the culture that GP practices, primary care networks, GP federations are going above and beyond QOF and really kind of driving that kind of a true achievement of various step change KPIs. So next slide, please. So what we've tried to outline here is some of the funding options at various levels within the NHS. So we know obviously things are very difficult at the moment with funding and change. It's not necessary that there'll be immediate funding available and that funding needs to be unpicked or need to be taken from elsewhere in order to try and fund prevention. It can be very challenging. So what we're offering as a partnership is to sit down with you as individuals to look at what you're doing already in regards to CVD prevention, how we might be able to support that activity, but then also to look at how we might be able to support you generate a business case for either moving money around the system to enable a program such as this to be funded this year. So at ICB level, that could be looking at how we look at funding elsewhere within the system and look at how that could be pivoted towards a prevention program within a GP federation or a multi-neighbourhood provider. This could be supporting a business case to bid for various prevention work streams. It could be aligning DES across the federation footprint. At primary care network level, there are some more tangible funding pots that could be used, but ultimately it's going to require a business case and an investment in order to sustain this progress. Thank you. For the next slide.
So just last couple of slides. One is how technically do you access CVD Action? So there's a couple of routes. One we've integrated with Eclipse, which many of you might be familiar with. They provide a lot of data services in, I think, more than 50% of the PCNs across England. So CVD Action will soon be available to access there. A second approach is we've developed it into a standard query language, and that can be applied to population health data sets, and that's the approach we took in Northwest London. But if that, on a case-by-case basis, we're really happy to kind of explore with you what your data infrastructure is, and therefore what's the best approach for getting CVD Action set up. There's probably one last question that you'll all be asking, which is how much does CVD Action cost? And we've not put it specifically onto a slide because it all slightly depends on your local setup in terms of your data infrastructure and what resource and implementation support you already have. But there are three kind of critical elements. One is the CVD Action license fee, which is 20p per head of the population. The second factor is just to think about technically how are you going to make CVD Action available within your primary care network or your ICB. And then the third is that implementation support. So our next slide will just say kind of what happens next, but we would love to follow up and have those kind of individual conversations with you just to work out how it works in practice. I'll hand to Matt for this final piece.
Great, thanks, Laura. And just to finish off, we built CVD Action specifically to enable a step change in CVD prevention. It's focused on step change to take us from our historical acceptance of the incremental change that we've had for decades. And it does it in two ways. One is to help us to systematically look for all patients who are on suboptimal treatment and therefore at higher risk of a life-changing cardiovascular event. So systematically look for those patients. The second element, because data is not enough, is to provide that structured support that enables primary care teams to work differently and so respond to the data and optimize at scale. And you can see from this that from the numbers that we've shown you, these are huge benefits for the here and now. This is prevention that's not for some point in the future. This is for today and tomorrow. And for primary care teams, as well as improving care and outcomes for our patients, it's that increasing the assets and capacity within primary care, transforming our ways of working, which will translate into all of our work, but embedding proactive care, holistic care into business as usual. So it increases efficiency, releases capacity, but of course delivers on QOF. And then more widely for our populations, these are large reductions in cardiovascular events in a short time frame. And we've demonstrated with the modelling the rapid impact that will have on activity spend, productivity, and outcomes for our patients. And because of that health inequalities functionality in CVD Action, it does enable you to take really targeted but strategic action on health inequalities. And thinking of how we resource the prevention shift in the short term, this does bring return on investment for ICBs within a year. So I hope very much you've enjoyed the webinar and got the information that you need. But we'll open now for questions.
Matt, there's one in the chat from Chrissy. Are you working in Wales? Saw CVD action mentioned in the PHW Wales CVD prevention plan and ABCD approach, which was launched in September 2025.
Yes, well, we've had lots of conversations with the teams nationally in Wales and have been supporting in various bits of work and developed Size of the Prize for Wales. They're very interested in CVD action. They're in a different place in the availability of data. And it's not quite as accessible as in England, so there are challenges with that. But we're in active conversations with them to see how we can help that shift towards a sort of step change approach.
Thanks. Akiko asks about the HIN support for implementation of CVD action. So there are 15 HINs across England, and some of them will be supporting CVD action. So it slightly depends on whether your HIN is one of those HINs that have signed up to be the kind of to be part of that national programme. And our understanding is they will be supporting in terms of engagement and communication and helping make the business case for change. So if your HIN is one of those HINs, yes, that support will be there because it's fully funded through their NHS England contract, if that makes sense. And Akiko, happy to follow up with you after to check whether South West HIN is one of those HINs. David asks, how do we sign up? Oh, that's what we love to hear. Please drop us an email at rosa@interaction.health so we can follow up with you to make that happen. David, do you want to come off mute and do you want to say anything to your comments? So David's put in the chat, our ICB has poor performance, so they're already pushing us to see how we can improve. So CVD action.
Yeah, sorry. So we're in Surrey Heartlands. I think they're third worst in the country. So they've been contacted, I think, by the Department of Health to try and improve things. So this sounds an ideal way. Money is always the issue, isn't it, really, for these projects? I think for our PCN, probably about 7,000. So that's probably quite doable from next year's budget for the PCN. And we've already worked with Dan and his team, who we're very pleased to work with as well. We're very happy with their work, which is excellent last year.
It's a great point, David. It is a challenge facing lots of ICBs. I mean, some have, as you say, much poorer performance than others, but all of us have a big challenge about how to do considerably better in CVD prevention. I mean, that is the national mission now, and I'm sure it will be writ large in the Modern Service Framework when it's published. And it's difficult to do, and there's lots of activity around. And I think historically we've relied on activity, lots of good activity, doing the right stuff in the hope that it will deliver at the end of the day. And historically, it tends not to for lots of reasons that we understand. And that's why we've kept very focused on what are the key things you've got to do. You've got to find the patients, you've got to help primary care be able to optimise them and embed that for the future business as usual, not as a sort of parachuted in project. You may well have lots of great stuff going on locally, and as others, PCNs and ICBs do. And CVD action is not a replacement for other stuff. It's designed to, augment, complement other tools that are out there. But it is very specific in its focus. If we do this stuff, and we support primary care teams to constantly look at the data, how we're doing, troubleshoot, how do we improve, with shared objectives. One of the approaches we take in working with teams is this is not something we're going to bring and give to you. This is about a partnership. So we would partner with teams at the beginning to agree, as Laura said, where do you want to start? What conditions do you want to start with? But help them set step change objectives themselves, and they have to be step change objectives. I think it's only with that rigorous approach on step change objective and data to check on our progress that we'll actually deliver on the mission.
I agree. I think data is key, isn't it? Because you can then show the benefit you're making over the period of time as well, which is always very motivating. So that's very helpful.
Is it Sarshini? Sorry if I pronounced your name right.
Yes, hi. Thank you, Laura and Matt. What a phenomenal platform and what deep insights this gives us. So I think this is really exciting as another tool in our armory in CVD prevention. Just a couple of questions. One is, do you have any case studies where PCNs have taken it up and run with it? Because often that's quite valuable if we're able to access that. Then it's really nice for us to be able to rinse and repeat in our locality. And the second thing is whether you have any patient materials that we can circulate. So actually, the patients are our sort of co-pilots in this journey, and whatever we can do to engage them early on is always helpful. So those were my questions. Thank you.
So I'll come onto so on the case studies, yes, and I'll put a link in the chat, and they were written up from the demonstrator program in London. So yeah, let me put those in there. In terms of patient materials, again, we have examples from the demonstrator program as to what was used. We've got some examples from Wandsworth, and we've got some examples from Northwest London. So we can request that they're shared. Matt, do you have anything to add on that?
Hi, Sasha. Nice to see you again a week later, and thanks for joining today. Yes, the range of materials that were developed as part of the London Demonstrator Programme, which we can also point to particular two things. I'd point to one was the implementation guide, which has a lot of detail about specific things that local teams have done and steps to take, but acknowledging that we would also support that with the IQVIA team. And the second thing has gone out of my head. So I'll come back to that in a second. I'm just hesitating to see if it just comes in, but it hasn't. So I'll come back to that in a moment.
Thanks.
Any other questions, thoughts, feedback? It's always helpful to us.